Our next speaker is Dr. Hiren Patel on cervical spine stabilization.
Hello everybody, I'm Dr. Hiren Patel. Thank you for welcoming me to Kenya and to the symposium. Before we begin, Dr. Ward brings the PowerPoint up. We have these finite spaces to talk. So I revamped my lecture last night after we had very intriguing and a lot of participation in conversations. So I was thinking, most of the neurosurgeons in this room know various techniques to stabilize the spine. So I thought I'd go over some techniques with a twist on it that make it a little bit easier to do some of the stabilization techniques. Maybe we can feed off each other and give each other pointers how you would do it in Kisumu, Nairobi, and so forth, because sometimes we have limited resources, you learn new ways that are more efficient and better. So there's a couple of techniques that we've published and I've learned along the way and kind of combined to make life a little bit easier for C1 and C2 screws. And I was going to just go over that in the finite time I have. Hopefully you guys can improve my technique. Can all the residents raise their hands? So the best way to start would be to start with a case presentation.
All right, we'll continue on with our talks. Our next speaker is Dr. Hiren Patel from Boston. Thank you.
Well, it's the unenvious task to follow the governor of Kenya, and so I had that slot, I guess. So I'm Dr. Patel. I'm going to switch it back to neurosurgery for a little bit, and like I discussed earlier, we'll go over some techniques that are a little bit different, and see if we can improve on each other's. So we'll start with the case. 81-year-old male, status post fall. It's very common in the United States to have an aging geriatric population that requires a huge neurosurgical need. Nope. So I go over the most common ER presentations of these patients. So the most common fractures and so forth. So he came with left hand paresthesias, left arm weakness from prior accident, and urinary incontinence, and he was quite sick at the time. As you can see, his right arm is pretty weak on exam. And he has this MRI. I think all the residents ran away when they heard us and asked some questions. They didn't see anyone back in the room. Okay, so this is a type 2 odontoid fracture with increased angulation into the spinal cord. As you can see, there's actually some signal in the cord you can't appreciate on the projector, but he's starting to have some ischemic compromise of the cord there with anterior and posterior or ventral and dorsal compression. So it's very common to see odontoid fractures in the elderly population. It's actually the most common fracture in the elderly. So we deal with these quite a bit. Most of the time we deal with them non-operatively with just a collar for 6 to 8 weeks. And then we do some flexion extension dynamic films to see if it's stable. And we do have pseudoarthrosis most of the time, and we can manage it expectantly without surgical intervention. We try to avoid surgery at all costs because of the advanced age, multiple comorbidities, and anesthetic risk. There's a couple of ways of fixing this problem, and I see Dr. Khalif has unfortunately walked back in. Can you give me one approach to fixing this problem? Okay, posterior, good. So there's two ways to really attack this problem, anteriorly and posteriorly. Anteriorly is very morbid. You have to do a transoral approach in autoidentectomy. From the literature's point of view, the morbidity and mortality is quite high from this procedure. That's why you don't see it as often anymore. So for most cases, neurosurgeons today, if they cannot treat it with the odontoid screw, which we're not going to for this lecture, it's a whole lecture on its own, we go posteriorly. Just briefly, an automatic screw is where we put a screw up from here, and we bring this fracture back down. Okay? And we have a date on that, but that's another lecture. All right. So here's the CAT scan. As you can see, this gap is not going to heal itself. And this is on flexion extension films. This is a unstable fracture. The fracture actually moves back and forth right there and compresses the cord. So he is the Lemaitre sign. And this is a scan of C1. He also has a fracture here in the lamina. And notice Dr. Gao did mention yesterday, which I thought was a good point. The reason we get CAT scans with CT axials, the thin slices, because we have to know where the vertebral arteries are. That determines our approach of stabilizing it and how we manage a fracture. This can vary on location, and I have two scans that show various locations of the vertebral artery and the transverse foramen. Okay, now this is important. So notice how medial and prominent the verts are in C2. This is going to change my plan of C2 screws if I decide to do that, because these are really shallow and medial. I have no trajectory for my C2 screws. So what I ended up doing was a harms fusion. All right, so I did C1 vertebral arteries because I did not want to do an intraarterial exploration at that time. The neck came for a few weeks, and his leg was given. So he had a similar recompense fracture, which was which was, would you put this guy in a collar? Right off the bat, until you figure things out? When he comes in, you hear the story, you put him in a hard collar, okay? You don't want to move his neck around or anything like that. You stabilize the best you can until you come up with a social plan. So, what else would I get besides an MRI, Dr. Stan? The CAT scan, correct. What am I concentrating on the CAT scan? I already gave you the answer. What am I looking at? Besides the fracture pattern. That's what you're looking at. This calcified disc here. Okay? Okay? So remember that. Just because you have other issues doesn't mean the patient is a big operation. Fix the problem causing the biggest strife, and then follow and address the other issues later. Okay, so this guy has C1, C2 related or lateral mass related. Always look where the vertebral. Now, what's wrong with this picture? You know, which one would cause me the most stress? Robust and could handle what's it called, luxury perfusion, or collateral flow if needed. But yeah, put the screw in. And the next step is to get an angiogram. Okay, finish quickly as possible if you want. The next step is the angiogram to make sure there's no dissection and we throw the clots up to the brain. All right. So now your next thing to worry about is if there's a dissection. Side note, I did do I had a chordoma at one time where we had to sacrifice proton beam because of artifact from coils. So if you're doing a cancer case, you got to think second and third tier. Well, my intervention now prevent treatment down the road. So we had to go in and actually physically sacrifice the vertebral artery, remove the coils so the patient can get radiation, proton beam therapy down the road. So there's something to remember. So this patient, because of that vertebral artery being right there, what type of screw would you consider for this patient, knowing they do not need a C2 laminectomy? Would you do a pars pedicle screw, transarticular screw, or a translaminar screw? So who would do a pars pedicle screw? All the residents raise their hand. No hand should go up. Alright? That vert's huge. You don't want to flirt with it. Alright? So the translaminar screw is not a bad idea, right? You got a thick lamina, okay? Then you take two screws, one screw going this way, one screw going lower, that way, right? So that's exactly what we did. We want to have boring, routine surgical cases. We don't want to have excitement. We don't want to have interest coming out of it. We want to go in, go out, and forget the case. We always tell our patients, you don't want us to remember your surgery. You want us to just remember, oh yeah, I want to access that. Okay? So now, some tricks I have to do C1 lateral mass screws. So, okay, and this is the bane of neurosurgical existence. The epidural plexus bleeds like crazy. Okay? So as you're dissecting down the bipolar patty, you're bleeding, you pack it off to the other side. And go back and forth and get post-op pain relaxing. So instead of, we start our whole entry point right there, in the inferior portion of the lamina. The diamond drill bit is fine, doesn't shatter like the matchstick does, and it starts the pilot hole. Now, what's the main concern about going too high in the lamina? Dr. Sam certainly answered every question to the lamina below, and you can start your. So after I do my C1 laminectomy first, I take my 4 Penfield and I palpate the borders of my lateral mass. So I bring it down here and I feel my lateral mass. Okay, so I know where medial is. Medial compartment right there with diamond drill bit. And I know that may not be available in Kenya, but it's just an idea you may be thinking about starting a drill bit. It has to be small, can't be big, and can't have a lot of motion. Okay, and I go 2 millimeters at a time in the beginning, and then when I pass the vertebral artery, reaches. So I go 2 millimeters at a time, I go up to 4, I get a little bit more aggressive. After I'm passing, explore internally. Internal carotid artery. Okay? So the C1 screw is not a benign screw. There's a lot of ways for the patient potentially crossing out the facets into the pars pedicle. Okay? This is lateral mass screw for and the verse massive, is the most common technique. Any other PGY2s that are above in the room? Sorry, but what's my target body? Your pars pedicle trajectory. I kept this one short on purpose because of the vertebral heart rate. Okay? So, any questions so far on that? And then the fluoroscopy, other than using a handheld drill. Patients anatomy. If you use 17 inches yourself in, it's really big. And so, even though it's above the facet, another caveat is various versions of need more. Okay, patients have larger distance to the lateral mass, where you need like 15 or something, that has to be specially made. Okay, but most commonly, and here's this machine. Okay? And I keep this a little bit proud. That's what's easy for my body again. So here is offset a little bit. They don't go in the same place because they'll hit each other. Alright, so this takes a little bit very well. Okay, same technique, tap, probe. And if you only take C2 lamina, this is a very good, easy, quick way, and safe way to stabilize an odontoid fracture. So usually I do transaminal screws, like if I don't have to do a C2 pars pedicle screw. Okay? And same concept. If I was going to do a pars pedicle screw, I did C2 laminectomy, I palpated with a 4 Penfield. Okay? Lateral to the cord. Alright? And that way I know my barriers. And then, so I do a combination of all 3 of these techniques. So there's 3 techniques, Marshall, Anderson, and I visualize lateral mass like a shoebox. Okay? And here's the shoebox. So that's the front, back. Alright? So I find the midpoint of the lateral mass, and I go 1 millimeter inferior, 1 millimeter medial. And I take the X-ray, and I try to get lowest on my lateral mass that I possibly can, and I aim for the outside corner of the box. So let's pretend, alright, this is a good picture. So this is the box, okay? So I take X-ray, I go to the lowest part of the lateral mass, I want to use as much of it as I can, and I don't want to get in the joint. And I aim for the upper outside corner. Does that make sense? So I drop my hand, inferiorly, and I angle up and away in a step-like direction up to the outside corner of the box. Okay? This avoids the vertebral artery, alright? And the nerve, and it stays out of the joint. Okay? It's an important, easy trick. Instead of memorizing all these angles, which, I'm not that smart, so it doesn't work for me. I have any simple analogies. So I imagine the lateral mass of the box, I go for the outside corner, and I use x-rays to get out the first couple. Now C6, and the patients, and Dr. Lavelle, and myself sometimes, they're not amenable to fluoroscopy after C3. Okay, so that's where this concept becomes more important. And the lower you go, the lower you need to be your entry point in your lateral mass screws, because your lateral mass gets thinner. Okay, it's harder, and also it's harder to angulate. So you have to kind of exaggerate your motions to get that corner. All right, and after you use a drill, you pro away with laminectomy. And then finally, if you're going to do a laminectomy, I do my pilot holes first. I fill them with flow seal or Surgicel, whatever I have. And then I do I like to do a lobster tail technique. So essentially what I do is, so I drill a trough at the facet lamina junction from C3 to C6, or to C7 where I'm going. Alright, and then I do on both sides. And I take two towel clips and I connect them to C3 and C6. I have a system of mine pull up on it, upward pressure. So this way, then I start biting the ligament away and it peels off. So I do a laminectomy in one full swoop. The advantage of this is, if someone has critical stenosis, you're not putting a kerosene in there and first in the cord. There's a couple of epidural bases here. And I think actually makes the surgery a lot quicker and safer. Okay? Here's just another, I don't know the picture too. So let's pretend this is my box, right? It's actually presented really well here. So I'll get my entry point right about there. Alright? So this is the midpoint, so 1 millimeter lower, inferior 1 millimeter medial. This entry point I'm going for this corner right here. Does that make sense? So here's the side view of the box. Alright, I'm going for this corner right there. And that works out well, especially if you have fluoroscopy. A lot of us do cervical fusion without fluoroscopy. We can't see anything. We just take it out. Would you read Dr. Lavelle?
Can't see past C3 sometimes.
Yeah, Dr. Lavelle said you can't see past C3 sometimes.
Their neck's as big as
Right.
thigh.
Right. And finally, I hail from Boston, Massachusetts.
Oh, really?
And we've had a 72-day drought of championships in my city. So we're kind of depressed right now. But, you know, Dr. War one day experienced my life. You know. So does anyone have any questions so far? Yes, sorry for picking on you so far. Yeah, I know you.
Use the mic and introduce yourself, please. There's one there.
Yeah, so the last case. The last of the two cases here.
Yeah.
So the fracture was unstable. So you met the stabilization, but the decompression part was not done, right?
Yes, it was.
So
Sure. So the first things first is get the spinal cord safe. Okay? Now, in the United States, we do these cases with neural monitoring. Why? When you go from supine to prone, this fracture is already moving. I can flip them prone and get the fracture to move backwards and compress the spinal cord. All right? I don't want the respiratory drive to be my neural monitoring. I don't want anesthesiologists say, hey, we can stop breathing anymore on their own. So we use neural monitoring to see if there's signal change. And often we do get signal change sometimes. About once every other month on a patient where I get 3 foot baselines, I flip them prone, and we lose all signals. And I'll try to manipulate the head under fluoroscopy, and there are Mayfield tongues, you know, and I'll try to reduce the fracture and get the signals back. And if you can't, you flip them back over and do a recheck. And let's pretend that you flip baselines, and they're very good. And then you flip them over, and you lose signals. Okay? You flip them back over. What are some things you can do to help your signals? You can direct anesthesia do this. So what does the spinal cord need? There's an image of some signal in the cord. Why did that signal happen? What does the spinal cord lose to get that T2 signal? Blood supply, right? So how do I improve my signals? How do I get the spinal cord feeling better? You have to do a wake-up test. You have to turn on, and neurosurgeons do this data now. You can't just say, oh, it's your doctor, call this number. Okay? So, I mean, that shouldn't affect anything you do to the patient. If I was on that table, how would I want it done to me? Okay? And that's how you should practice. But the main thing is the safety is spinal cord. Decompress first, make the spinal cord safe, and then put your screws in. Okay? Go ahead.
Yes, this is the same question of compression first. So you have an unstable
Another part?
yeah. The current is unstable. If you decompress, you make it more unstable. I don't know what the reason to start a decompression before putting screws can help you.
So the patient that may feel pins, right? He's not going anywhere. Once I flip him and put him pins, that fracture's not going to move. Okay, he's stabilized by the fix. It's like a halo, essentially, right? So I decompress him to get the spinal room to breathe. All right. And usually after every major maneuver I do, will be one of my motors. Okay, with their monitoring. I decompress it. Now the patient's safe. Okay, now I can take my time, do my compressing, close him up. That would be very silly of me. Okay, because he's unstable. Yeah, he has room in the back, but that's the ventral compression is still going to be there. Okay, so you can do the land mechanism stabilization. Good question.
Final question?
Or whether there's a school of thought that says you could actually just cut off the C2 nerve. Do you have any experience with that? Are there any colleagues who have any experience with that? I've never done it myself, but I keep on getting the discussion all over again that when it's not possible to place a screw properly, then you just
Right. So cutting C2. The problem is your ganglions there, right? And that's caused post-op pain and numbness. You're supposed to, when you cut the nerve, you gotta do it before the ganglion, and then you make sure you close the dura up properly because you CSF leaks. But with the new technique I showed you, we're going infiltrating the lamina, you don't have to worry about C2 anymore. So, I mean, I've never had to sacrifice, I've been freed up by dissection, so I've never had to do that. So I actually don't know anyone that's had to do that, but maybe.
I do the C2 rhizotomy sometimes. The indication for me is going to be in a lot of patients where you can reduce them really well, and then the bone heals, and that's it. But in some patients where we see a lot of very crazy trauma sometimes that you can't get a perfect reduction, it's not good contact. So I want to rely on that joint to actually fuse. In those patients, I do a rhizotomy. It's actually pretty simple. You don't have a C2 rhizotomy. We're going to move on to the next one. Thank you, Dr. Patel.
Exactly.